So my name is Betsy Stubblefield Loucks. I'm an outcome broker with the Green and Healthy Homes Initiative. We are based in Baltimore, but we have a Rhode Island office, and we've been here for about 6 or 7 years. What I was I'm going to talk a little bit today about what GHHI does, but the reason that I wanted to be here was to share with you all an idea around financing. I'm sure many of you have heard of the term social impact bond. Another term is pay for success. So GHHI has a couple of different pay for success projects that we're doing feasibility studies for now across the country. I'm learning about it myself, and am excited to share this idea with you all and see what kind of questions you have. But first I'm just going to start with a little bit about us, because that's important to understand our model for a social impact bond. So these may be some numbers that you all know, that unhealthy homes drive unhealthy families, and that's a huge healthcare problem. It's an energy problem. It's a community resilience problem. 9 million families live in unhealthy homes across the country. We spend annually billions of dollars on dealing with problems that originate in the home that are essentially fixable problems. They're not huge epidemics that we don't know what the cure is. We actually do know that if you take lead out of a home, you're not going to be poisoning kids anymore. We know that if you seal in a home and you haven't gotten rid of mold, or you haven't gotten rid of asbestos, that you're going to make that family sick. So even if you have funding for energy efficiency and you seal that home in, you're not really doing anyone any favors. We spend $43.4 billion a year dealing with lead poisoning as a country. $56 billion a year dealing with asthma, and that's mostly among children. $19 billion in dealing with falls for seniors. So just keeping in mind these kinds of outcomes for stuff that we know how to fix with hammers and nails. Some of the data for Rhode Island. 82% of low-income children in Rhode Island live in older housing. Not that there's anything wrong with an old home, but in Rhode Island, an old home comes usually with lead and mold and asbestos and old snowman furnaces. I know because I have one in my own house. In Rhode Island, we have about 2,000 children a year that are hospitalized for asthma. Half of them are from the 4 core cities. 10,000 emergency department visits for asthma. 6,700 children are chronically absent from school in Rhode Island because of asthma. And in 2016, nearly 1,000 children under age 6 will have elevated blood lead levels. We've had lead laws in place in Rhode Island. We have excellent lead laws in place, and we still have this problem. And as we've seen this year, well, now I can say last year, in Baltimore, with the case of Freddie May, he was a lead-poisoned child. When he was 3, he had elevated blood lead levels that were 15 times the safe amount. And once you get lead poisoning, you're really on a dark road. It has an impact on your behavior, on your learning styles and learning capacity, and that really has a big impact on the kinds of jobs you can get, and on and on. So that's the context in which we're doing our work. And not to forget, we often talk about healthy homes, and when GHHI talks about healthy homes, we're also talking about energy efficiency. Low-income households spend 14 to 20% of their income on energy costs, whereas the rest of us spend about 3.5%. So that's something to keep in mind. So this cycle here is one that we're actively working to address, and this is where our social impact bond comes in. If you have an unhealthy home that's triggering asthma in your child, it causes them to have to go to the hospital. Say the hospital spends $1,000 on the emergency department visit. They send the kid home with a $15 inhaler back into their home, where they get asthma triggered all over again, and back they go. The families that we work with in Baltimore send their kid to the emergency department for asthma at an average of 6 times a year. So that quickly adds up. There are a lot of people trying to help. And here are some of the silos that are trying to help. And that's one of the problems that we're facing as well, is that there is funding out there, but it exists in silos, it's not coordinated. And that's where GHHI comes in, where we're really trying to streamline. One of our mottos is we align, braid, and coordinate resources to serve families. And so we work with philanthropy, with federal and state funders, and the private sector to fill in the gaps and really try to braid together the resources that can help families out of this spiral. We've had external evaluators do work on evaluate our programs and also other comprehensive healthy homes interventions, and they found that there's a return on investment of $5 to $14 per dollar invested for this kind of comprehensive home health work that we do. And that is where the PFS stuff comes in, the social impact bond, because of that return, because somebody can make money on a return like that. So that's the place is set. Just what do we do about that here in Rhode Island? What do we do about the problem that I just presented here in Rhode Island? We work both on the ground and upstream. On the ground, we work with low-income families to get them resources for energy efficiency, lead hazard reduction, healthy homes assessment, and rehab interventions. I'd be happy to tell you in detail more about how we do that. This year we're hoping to work with about 200 families, and we'd love to go to scale, but that's the scale that we're operating on right now. We also work upstream. I run the Rhode Island Alliance for Healthy Homes. It's an alliance of over 70 organizations and 500 members that all care about healthy housing. So if you're interested, let me know. We'll sign you up. We are looking more upstream at the policy and funding sources that are driving the programs for healthy housing and for helping families. Okay, so here's the social impact bond stuff. So Pay for Success is this innovative, because everything's innovative now if anybody wants to pay attention to it. It's a new method of paying for social problems based on outcomes. The funding comes from private investors who are paid back by government or healthcare organizations only if predetermined outcomes are met. So ideally, a Pay for Success intervention is evidence-based so that you know what you're getting into. It's preventative as well as delivering a service, and it generates cashable savings. So here's the model. You have an investor who presents funding to an intermediary who structures the whole works, and they give the funding to a social service provider. So in the case of JHHI, we get the funding in Baltimore. We get it from a couple of different investment firms who front the money to us, and then we provide the service to the population that needs it. And they achieve their outcomes. So they avoid hospital visits, they avoid missed school days, they avoid missed work days. And because of that, somebody saves money. So in our instance, what we're talking about is hospitals saving money, healthcare providers saving money. And because they've saved that money, then they pay that money that they saved to the payer, so the government payer, who then pays the money to the intermediary, who pays back the original investor with a return. If the outcome is not delivered, then the payer doesn't have to pay. And that's the lost money is paid for by, I don't have that slide, is paid for by like a philanthropic organization who says, well, it was a good investment and we'll measure our outcomes in other ways. But hopefully this doesn't happen because we've done our homework, we've looked, and we know that by doing the intervention that we're doing, we're going to get the outcomes that we expect. The hospitals are going to save money, and they can give the money that they save, they can pay back to the original investors. The hospitals would pay less than they would pay to handle that caseload, but that is still more than what the investors fronted, and so the investors make a small return. I know I went through that really quickly, so I'm seeing a couple of furrowed brows out there, and I'm excited for the Q&A session. So the benefits of a Pay for Success approach to addressing a social problem is that it is progress towards systemic change, because this approach to funding interventions is scalable, and it's making somebody money, and if we're going to be using the market to the extent that we are in the US, we might as well use it to have positive social outcome. It bridges a timing gap between service provision and cost savings. As many of you know, I'm sure, when you're in the social service sector, it can take some time to actually demonstrate that your return on investment was made good. and this helps bridge that gap. You pay for what works, so first you have to demonstrate that what you're doing works, and then you pay for it and you take it to scale. It's stable and flexible funding to service providers, which I'm sure many of you struggle with that. I know Melina and I were talking about money coming and going, and stability is key to delivering high quality service, and so this is a funding mechanism that drives that stability. It shifts the focus from remediation. I hate that term remediation. It's like, you know, something's broken, oh shoot, you know, now we have to go and fix it, and like, let's just wait for everything to break and then we'll find funding to go fix it, instead of preventative, let's keep that bad thing from happening. And so the Pay for Success model really takes that approach of, let's prevent some of these big cost centers that are coming down the road. If we can fund it this way, we'll be able to prevent you know, lots and lots of kids going to the emergency department for asthma attacks. I don't know why this is called a benefit of PFS. I would say it's critical to PFS is that, that there be really strong program evaluation. I guess it's considered a benefit because in the way that GHHI structures Pay for Success, evaluation is a critical part. It's always there. I'm happy to kind of go into more detail around what actually makes it work, but I'll during the Q&A. But essentially, some of the main keys are that you're doing something that is evidence-based, you know that it works, everything is structured for evaluation, so all along the way you're evaluating, are we doing what we said we would do, are we doing the thing that we said worked? And another key is that there has to be cashable savings, so there has to be a way to capture the savings in a way that somebody can then take that fund and invest it in something else, hopefully another social impact bond. It has to be cost effective, and then not obviously currently well funded. You wouldn't want to do something that's already well funded and set yourself up in competition that way. It also needs to be scalable or replicable, and so that's why we're doing this on asthma. And I realize I missed a slide, but the way that we're doing it is we're getting investors to front the money to the Green Healthy Homes Initiative that then goes into homes, does this comprehensive home health audit. We go into the homes where there are kids who have asthma, and so we go in and we remove the asthma triggers and we do the complete Healthy Homes assessment and then do the intervention. So we get rid of the asthma triggers, we take out old carpeting, we get rid of water sources, we fix fans, we get rid of pests, we remove volatile organic compounds. And actually we found that within a year we have, with most of the families, we've reduced ED visits down to 0, from an average of 6 down to 0. And so families really do see that benefit right away. So at the end of the day, what we want to see is that healthcare payers recognize that paying for this kind of stuff in the home is actually going to help them meet their responsibilities and meet their needs. We want for doctors to see a kid who has asthma, instead of just giving him an inhaler and sending him back home, to say, well, what's going on in your home? I'm going to prescribe for you that somebody come and do a Healthy Homes audit and make sure that I'm not sending you back into the place that brought you here to begin with. And in some ways, this would make housing professionals kind of a new front line on healthcare, which is an exciting concept to me. Overall, this work, you know, we always say home is where the heart is. I mean, this is really, home is where the body is, home is where you're breathing, home is where you recover from being sick. And so when we have healthy homes, we would have a healthier society overall, and that's our goal. So that's my presentation. Any questions? Yes.
Yeah, you mentioned lead briefly, but you're not really addressing asthma rather than lead poisoning.
In the PFS, in the PFS project,
yeah,
it is targeting asthma.
Yeah.
But as part of our comprehensive home audit and assessment and intervention, if there is lead in the home, we address it.
Okay, so there's another piece of lead poisoning is the massive amount of beautiful blanket of lead dust we have in the ground all around. I don't know if anybody's dealing with that.
So the question was about the blanket of lead that we have in our lovely state of Rhode Island. Right, it's why I have whiskey barrel garden instead of a garden in the ground where I live, and I don't let my kids play in our yard because there's lead in it. And so we work mostly with the structure of the home, and the way the regulations are set up in Rhode Island is that the Housing Resources Commission oversees the house, the Department of Health oversees the bodies that live in the house, and the Department of Environmental Management handles the environment in which the house sits. So mostly because I'm working with the house and the bodies in the house, I don't know what's going on with the dirt. But one thing that we do is resident education. And so we do work with the people that are living in the homes and point out that outside of their home is probably also lead contaminated. And as part of a lead inspection, the soil around the home is also included in that lead inspection. And whenever we get those results, we always go over that with the families. So outreach and education is a huge part of it. Remediating lead that's in soil is, you pretty much can't do it. You have to cover it up. You have to build elevated beds if you're gardening. You have to cover it with mulch or soil. You can't take it out. It's never gone. Yes, in the back. Yeah, you, not Kurt. But
So your interventions, are your interventions chiefly in owner-occupied residences, or do you have to sometimes deal with, landlords?
We have to deal with landlords a lot. So we will work with anybody who's a tenant or renter, owner-occupied. In Providence, we have some interesting challenges because we have triple deckers, which are not quite multifamily in terms of energy assistance programs, but you often have one single landlord. Sometimes you have tenants who want our services, but the landlord doesn't want it. Sometimes you have the landlord who wants the service, but the tenants don't want it. So it's definitely tricky territory. Kurt, did you have a question?
So my brow furrowed when I understood that the investors got paid back no matter what. That was my understanding was, as you said, when there weren't demonstrable results, then a philanthropy steps in and gives the money. I mean, is it just that they get their investment back?
They get their investment back. They don't get the return back. They get their investment back. Yeah.
So I guess the good news is, it is actually risk-free investments, and why would they not all just do it?
Ladies and gentlemen, Kurt Teichert. Right? Well, and everybody's excited about it.
Right.
The Governor Raimondo is doing this in a couple of different fronts. It's been done in juvenile justice settings. It's being looked at for a lot of different topics. But, buyers beware. This is not going to work everywhere. This is not a panacea. This is one thing that JHI is really trying to understand is what makes a good investment. And one of the questions that I have is, why do the investors get the whole return? Maybe the families should get something from this. They're the ones that are kind of being the guinea pigs. Did you have a question in it?
Yeah, so in places where, do I assume correctly in Baltimore, the PFS is running to scale?
Well, we have, no, it's not running to scale. We did a demonstration pilot that was very successful, and we're now structuring and doing feasibilities. Baltimore is one of the sites. There's 10 sites across the country. Maybe one will be Rhode Island. You didn't hear that from me. But we're looking at structuring it in many different sites across the country.
I'm just wondering if that intermediary, or thinking of them as a syndicator perhaps, is there a prospectus for, in order to really grow the program investor-wise, even if the person, especially if they're not going to lose their original capital investment, that would be a great thing to be able to use the program as broadly as possible.
Yeah, we're in the process right now of sort of developing. We have the technical capacity, and so we're trying to codify that and share it. We're a nonprofit, so we're not trying to. This is not something that we're trying to kind of hide. Our intellectual investment in it is one that we want to make sure that gets recognized. But we want this to work, and we want everyone to do it. Oh yeah, you're in the dark. I can't see a thing.
So to the point about the hospitals paying back the investment, have there been cases where there has been a demonstrated need that's really important, but the potential cost savings of the hospital isn't actually the amount of money that it costs to do whatever is needed.
That's a tricky part. So the question, let me make sure I got it right, is with kind of how do you qualify or quantify what the hospital has saved from, I mean that's one of the biggest challenges in public health, is saying that this intervention has prevented some public health catastrophe, and how much would that catastrophe have costed, and who would have paid for it. So that's why asthma is a good target for this, because we really have good data on how much it costs to pay for a child who has asthma.
I guess maybe my question more concretely is what is the negotiation with the hospital? Do they agree to pay whatever those 6 emergency room visits sort of cost, or do they agree to pay a percentage of the renovation, or like what is the arrangement typically?
I'm not sure. I'd be happy to find out. If you get my card, I'd be happy to get back to you on that. I don't know how it's structured. Also, I think it depends on the group. So in the 10 sites that we're working with, the hospitals are in different arrangements. You know, some of them are ACOs, some of them are community health centers, some of them are, you know, paying through Medicaid. I don't think we actually have, well, actually, I think in Springfield we're working with a Medicaid payer. So we're doing a lot of research on this and figuring out, there's probably not one way to do it, but everybody has to be in agreement for the one that they're participating in. Mariah?
Are insurance providers at all involved in the payback piece of it? The insurance that saves money by not having to pay out to the hospital or whatever?
Yeah, so they're kind of in this role. Animations are only fun to a point. So where are the insurers? Oh, wrong one. So they're the payer. So number 6 there, the government agency, so Medicaid in our circumstance, or the payer when we're talking about asthma would be often is the insurer, and it can be private or public. Yes.
How many of these have you done?
So we've executed, I think. Well, we've done at least one in Baltimore. That was the original one that was done in partnership with Johns Hopkins. And we have funding from the Robert Wood Johnson Foundation, Clinton Global Initiative, and the Calvert Fund to do feasibility studies in 10 more sites.
And was it successful?
Oh, yeah. Yeah, I mean, that was the return on investment, I think it was 8 to 1, but don't quote me on that. I can get back to you with the actual study. It was published, and I'd be happy to send that to you. So it's an exciting opportunity. You know, we're going into it eyes wide open. You know, really hoping that we're able to deliver. The concept has been cleanly demonstrated in Baltimore, and stay tuned. Thanks for your time.